Thank you very much for the introduction. And I know it's usually quite hard to give the last presentation of the day, so I'll do my best. I'll try to distract you from thinking about what you want for your evening lunch. So I know we have drug-drug interactions, but I'll do my best to distract you. So the outline of the presentations basically going to have a small few slides on the general epidemiology of hepatitis C, treatment of HCV with the new DAAs, the general drug-drug interactions, and move on to a little bit more complicated drug interactions. Then perhaps, because we can't remember all these drug-drug interactions, what kind of resources and some conclusions. So I'll start off with this, and often a question that we see numbers all the time, but when we're talking about hepatitis C, how many persons are globally living with chronic hepatitis C today? And if you don't know the value, just guess, or just do what you want with this one, because we see a lot of numbers. You probably recognize some of the numbers. So it's a bit of a spread, so maybe a lottery. So as you can see, I will go to the next slide, but most of you have gone for the 257, and then next one around 142. So you've gone really for the high numbers, and then we have the middle numbers here. So actually, if you're the number 4, congratulations, you are correct. The other numbers, the 257 is hepatitis B. Actually, I trick you. This one is HIV, and the other ones are just random numbers. So as we go to the global map of hepatitis C, we see 71 million infected by predictions. You see in the North and South America, not so much, but really more focused in the Middle East and Southeast Asia. But when you compare to, HIV and hepatitis B, you can see that actually the distribution is actually more heterogeneous. Because for hepatitis B, we see a lot in China, in Southeast Asia. For HIV, we see in the sub-Saharan Africa. But when you split by region, really for HCV, you see that the distribution within the regions is quite similar. And in terms of, the prevalence, overall around 1%, but it is really quite similar across these regions. So compared to hepatitis B, HIV, you see it's a bit of more of a spread of the epidemic. When we look at the deaths compared to the other, common tuberculosis, HIV, malaria, just to note this is hepatitis, so it includes hepatitis B. The number of deaths are high, it's continuing to increase when you see HIV coming down, and then mainly due to cirrhosis and liver cancer. When you look in the HIV population, around 6% are co-infected with hepatitis C. That might be increasing with the data we see that we just mentioned from Bangkok, but getting more data in this group would be interesting, particularly in Southeast Asia. So basically, as we've seen on the last presentation as well, all those with HIV should be tested for hepatitis C as well. So the genotype, compared to HIV, we know that, we don't so interested in the genotype for HIV, but for hepatitis C, the genotype is very important to determine which is the best regimen to use. So apologies if you're not from Thailand, but maybe you can have a guess at what is the most common HCV genotype in Thailand. So most of you genotype 1, genotype 2, genotype 3, and here. And again, maybe I'm playing with you a little bit. The answer is C again. So those are answer to C. When we look at the distribution of the genotype within Thailand, the hepatitis C, and this is in the different regions, it's quite similar within the different regions in Thailand. The purple here and the blue, which is all hepatitis genotype 3, genotype 1, genotype 3, and a bit of genotype 6. So genotype 3, genotype 1, quite similar, but probably more genotype 3, and then genotype 6. But again, if you look between the south and the north of Thailand, the distribution is quite similar. But if we look across Southeast Asia now, and you look in Laos, for example, you see now you're really switching to genotype 6. Also in Myanmar, you have genotype 6 more, but when you look at Malaysia, for example, really limited genotype 6 but mainly genotype 3. So even within the Southeast Asia region, within Thailand not so much, but when you look in the global picture, you see quite differences between Singapore, Malaysia, and, for example, Thailand. So it is quite important which country you're in to see what is the genotype. So another question, we'll get the questions out the way early, and this is a little bit of a trick question, and maybe you would argue what was the right answer, but how many DAAs are currently available in the market? maybe more focus on the newer DAAs as well. So I think, yes, what you've looked at is 13, 9, and 17. So actually, I've changed it this time. So basically, what the idea of this question is just to really highlight that there are now a lot of DAAs on the market. And there has been some earlier ones like boceprevir. These are not really included, but in this WHO document, they're saying as of today, there's around 13 DAAs. And they're like HIV, you know, they're split by their mechanism of action, depending on where they're working in the cycle of the virus. So these are the most common drugs now. We know, probably most of you know sofosbuvir, which has been sort of like the backbone now for a lot of the regimens, which, at least in our region, and we have these different options available. And when we look at similar to HIV, we've just learned all this, you know, there's 26 HIV drugs around, and now we have to learn all the hepatitis C drugs. You have these individual formulations, which can obviously be combined, but now they want to try to give, you know, fixed dose combinations of these treatment, and now there's, you know, 1, 2, 3, 4, 5, 7 fixed dose combinations, which are very useful for, you know, treatment for hepatitis C. So what are the treatments that we give? We know that with these DAAs now, cure rates are more than 95% if you have, you know, 8 to 24 weeks of treatment, depending on the genotype, depending on the source. So with minimal toxicity, so very, very effective. So for having very toxic and, you know, ribavirin, peg interferon, which were not working, to suddenly having 95% cure rate, it is quite a big change in the last 10 years. So the WHO came out with some new guidelines earlier this year, and now they're basically recommending, you should recommend treatment for all individuals with hepatitis C more than 12 years old, irrespective of the disease stage. Now, this is, again, it's a strong recommendation, but, you know, moderate quality of evidence. So, again, this could be discussed whether this is correct or not, but this is where they're going. I think they're trying to, similar to HIV, you know, treat everyone if you can. And this is what they recommend for over 18. It's split by, you know, with cirrhosis or with compensated cirrhosis. So you can have very short treatments. You can have soft aclastovir 12 weeks, soft lifidavir for 12 weeks, and even a shorter regimen. I want to thank the names. It's called GP, 8 weeks. So you can have 8 weeks of treatment in this relatively, you know, without cirrhosis, a very potent regimen. But then when you go for the compensated cirrhosis, you have to have a little bit longer treatment. Still not too long, you know, 24 weeks, 12 weeks versus what it was in the past, you know, for a year. So I think there's still very good regimens available. So for adolescents, if you go down below 18-year-olds, so there is less options available. They recommend soft lifidavir for 12 weeks, but it's only for a specific genotype, and then maybe even soft ribavirin and soft ribavirin for longer if it's genotype 3. So clearly that it's like HIV. We have these drugs which are very good in adults, but then, you know, it takes time to get the studies done to get them down into adolescents and then even into children. So really there's some argument, you know, do we need to treat a 5-year-old child with hepatitis C? So at the moment they defer treatment, but you could argue that if you have a 12-year-old child or 11-year-old child, they were likely infected at birth, so they've been on treatment, they've had hepatitis C for 11 years. Well, there's still quite a long time to have this at that early stage in life. So there's a lot of debate now about starting the treatment. So you may be thinking to yourself, oh, he's been talking for 10 minutes and he's not mentioned drug-drug interactions yet. So I just wanted to I will now start to talk about drug-drug interactions. And we can see that for hepatitis C, basically 2 drugs, but depending if it's maybe you're naive or not naive, you will need to have, can be up to 5 drugs, but often just 2 drugs. But clearly there's a high potential for drug-drug interactions, if we see similar to the TB, when you're treating 2 diseases. Clearly HIV, HCV co-infection, but also for immunosuppressive drugs after liver transplant, for example. And of course, there's a lot of drug-drug interaction studies done during drug development, but actually, obviously it's impossible to really, you know, to study all drug-drug interactions. As you get an older population, they take more drugs, so you just have to really be vigilant for looking out for unexpected interactions. But today, I'm really going to focus on, you know, there's thousands of drug-drug interactions we could for different combinations, different drugs. So, but what I thought I would do to try to limit it, to try to, you know, focus it on what I think that you will be faced with in the future, is these are the 4 drugs really that are really going to be used, I think, in the Southeast Asian region for now. These are probably a little bit expensive, but may come in the future. So that's really sofosbuvir with the aclastovir, or maybe with soft lifidavir or soft lifidavir. So those are the drugs that, in this presentation, I'm really going to look for the drug-drug interactions. Now, in the drug-drug interaction world, we take it for granted when we're discussing an interaction, but I think it's important to highlight that when we talk about interactions, we normally talk about a victim drug. So this is the drug that's being impacted. So, something that's being, has a problem, maybe having their wallet stolen or something, you are the victim, but the perpetrator is the one that's causing the interaction. So in this case, we're going to see who is the victim, who is the perpetrator, and then often we will switch that, and then there will be the opposite. They can have an effect on each other. So when we talk about drug-drug action, we say, oh, this is the victim drug or the perpetrator, and we can see in this case, it's either going to be hepatitis C is the victim, or the perpetrator will be antiretrovirals. And we saw a lot this morning, again, again similar to the presentations on TB, where we look for drug-drug interactions. We're really talking about drug transporter interactions and metabolism interactions. So in drug transporters, you see that getting into the intestine, going into the kidney, or going into the liver, you need transporters which are pushing drugs and other things in and out. And if you had, for example, a drug which is metabolized in the liver, where the enzymes are here, and then you have a perpetrator that says, oh, I'm going to block these transporters, it means the drug doesn't get in, it doesn't get metabolized, and perhaps the levels are increasing. So there's many different transporters. I can't remember all the names, so don't worry about that, but I think that we need to see that this is the mechanism of how drug transporters can interact. For enzymes, of course, we saw with the TB, you have rifampicin, which we know is an inducer of CYP3A. So if you have a rifampicin, which would be the perpetrator, and you have a drug like this morning, the antiretrovirals, dolutegravir, it's going to reduce that level, so you have to increase the dose. Or you have on the opposite side ritonavir, which is a blocker of an enzyme, so you have to maybe reduce the dose. So again, it gets a little bit complicated with the drug metabolisms, whether it's an inducer, whether it's an inhibitor of drug transporters or enzymes, and can be a little bit difficult to predict. And then you see a table like this, which is just really, a little bit, looks like a crossword puzzle, really. And what it's really trying to show is that here on the left, you have the transporters, maybe these 4 transporters, and these are enzymes. So if we look at the drugs I said we'd focus on, like SOF here, softiclastivir, lebivizir, SOF, you see that there is some inhibition and substrates for these transporters, not so much for the enzymes. But when you look at something like SOF-VEL, there's a lot of substrates, and some of them are inhibitors of these transporters and for the enzymes. So potentially this combination, maybe you would expect to have lots of potential drug interactions, because we know in advance there is lots of inhibition of these enzymes and transporters. So this is a case, it's just a fictional case, actually. I'll just put it in, because what I wanted to try to steer you towards, where the drug-drug interaction, or where the kinds of things that you'd have to think about if I expect in the future, when you have access to the DAAs, or if you have access to them already, what are the things you need to think about when adding on hepatitis C treatment? So here we have a 49-year-old male, diagnosed a long time ago, started treatment with the standard of care, 1 tablet once a day, a tripler, doing very well, chronic hepatitis C infection, and now you have access to DAAs. You think, oh, maybe I would like to treat that. They have a confirmed hepatitis chronic infection, genotype 6, but treatment naive. And you're going to plan to treat with SOF-VEL, okay? So if you're going to do that in this setting, so HIV infected, you're going to treat with SOF-VEL, genotype 6, and maybe you don't know this yet, because I'm going to tell you on the next few slides, what are the type of ARVs would impact the SOF-VEL that you're going to prescribe? So they're on a tripler, or tenofovir, FTC, efavirenz. Do we expect that to interact with the SOF-VEL? And which one would it be? So everyone's put efavirenz, because we know efavirenz is a nice one to interact because it's an inducer and everything, but it is correct. Well done. So we look at the data, and if we look at SOF-VEL, so here the victim drug is VEL and the perpetrators are ARVs. And if we look on this graph, maybe I'll just orientate you to this graph. So this graph here you have split by regimen. This is the VEL concentrations or VEL levels, and this is the middle line, so 1. So if you're below this line, the VEL concentrations are going down, or the PK parameters are going down, and if you're above these lines, you see the concentrations are going up. And you can quickly see that when you give efavirenz with SOF-VEL, you're going to reduce the VEL concentrations, the exposure, the Cmax, the Cmin. While you see a similar NNRTI like rilpivirine or an integrase inhibitor, DTG-RAL, had no effect on on VEL. So here you see that the most common regimen now used for first line at this moment until dolutegravir is still efavirenz. It's going to reduce the VEL concentrations by 50%, which is it's not good for the hepatitis C treatment. What about for other treatments? Again, it's the same kind of graph. If you're going up, it's the VEL concentrations are going up. If it's not, so if you have boosted PIs like atazanavir, darunavir, lopinavir, or valtegravir with cobicistat, you see not too much. Here it does look like it's going along, but when it's interesting when you read the article, they say, oh, it looks very high, but it's still within the normal range, when it looks very high to me, but it says it was deemed not clinically relevant. So when you're looking at this regimen, it looks like clearly the efavirenz is a problem, but for the other third agent drugs like boosted PIs, it doesn't seem an issue. But then what about the opposite? What about if we switch the victim drug and the perpetrator? Now we want to see, does soft VEL have any impact on the antiretrovirals they're taking? We know efavirenz is impacting the VEL. And you see here, again, the black line. So if you're going above this line, it's increasing and below. So if you add here, you see that this is tenofovir. So with adding soft VEL to a tenofovir-based regimen, whether it's efavirenz, with tenofovir, rilpivirine tenofovir, or valtegravir tenofovir, they are increasing the tenofovir concentrations in the plasma. So it's sort of a double interaction. You have this decrease with VEL and with the efavirenz, but at the same time, it's increasing the tenofovir. And so this is an interesting regimen and you have to think about these interactions. I think soft VEL with efavirenz is not recommended, but with the tenofovir, it's perhaps still okay, but maybe close monitoring is needed. Similar, again, when you give soft VEL with boosted PIs, the tenofovir is also increasing, so it's not just with efavirenz or non-boosted regimens. And we know already that tenofovir levels are already higher with boosted PIs, so here you're adding this on top, and it's probably going even higher. So this is a little bit tricky. So giving soft VEL with a boosted PI, the tenofovir concentrations are going to be up somewhat higher than without the hepatitis C treatment with soft VEL. So for a second case, again, we go, this one, a female, 50 years old. They've been on treatment. They failed the first line. So this is GPOV in Thailand was a nevirapine-based regimen. So they switched to an atazanavir-based regimen with tenofovir again, doing very well. This time genotype 1, treatment naive. And this time, again, just to emphasize a point, there are other options. Obviously, the options you have, say you're in a country which only gives you soft declastovir, what are you going to do in this case? So again, similar question, which ARVs in this regimen, tenofovir, 3-TC, abacavir, do we expect to impact declastovir? Oh, sorry, give you the answer, Nelly. It's a little bit of a trick question, this one, isn't it? It's not an easy one. Okay, so we have atazanavir, all, and tenofovir. So, and I think that's a reasonable. I think actually all of them are something which could be sort of argued a little bit, because here we see for declastovir, here again the victim here is the hepatitis C drug, and now we're seeing what is the effect of efavirenz or atazanavir in this case on this. So for atazanavir, actually, it reduces. You have to reduce the declastovir dose from 60 milligrams to 30 milligrams because it really does. The ritonavir or the atazanavir is increasing the declastovir levels. So if you're giving an atazanavir-based regimen with soft DAC, you're going to have to reduce the declastovir dose. But what's interesting, and this is why it was a little bit of a trick question, we would assume then all boosted PIs would increase declastovir. So you would have darunavir, lopinavir, valtegravir with cobicistat. You'd think that it's a class effect that is increasing the declastovir. But actually, when they did the studies with darunavir, lopinavir, they didn't see it. So actually the dose adjustment with declastovir is primarily for atazanavir, ritonavir, not for darunavir or lopinavir. Now, what happens if you're on the first line just for efavirenz, for example? You see for efavirenz, again, it's a little bit tricky, declastovir, because here you'd have to increase the declastovir dose because of some induction of the enzymes, which is reducing the declastovir exposure. So declastovir is a little bit more complicated when giving with antiretrovirals. You have the fact with the PIs, a little bit complicated, especially if on atazanavir, and with efavirenz, again, dose increase. Not necessarily need to change the regimen, but you have to really look at the declastovir dose. So the final case actually is now an adolescent. So 16 years old, just diagnosed last year, but now, you know, they start treatment immediately. They started with the first line in Thailand, efavirenz, surprisingly for an adolescent doing well because I made it up. But then chronic hepatitis C, again, the question is not here, as I'm not going to ask should we treat or not, but say we are going to treat, we know from the WHO guidelines it has to be treated with the soft ledivosvir. So again, just for your idea, what would be, I don't have a question. So it's an easier one. I thought I was going to say what would be the interaction between these drugs, but actually as we saw for soft-vel, efavirenz was the problem. So the question is efavirenz going to be a problem with this regimen like it was for soft-vel? And he's shaking his head, you sure? No, you're correct, well done. Well, actually it does have an effect. So it does have an effect, but it's not as a big effect. So for soft-vel, you do see with efavirenz, you see, you know, 50% reduction more so. But here with ledivosvir, the impact of efavirenz is around 30%. And there's no impact on the soft. So you can see that there's a moderate reduction of around 30% in ledivosvir AUC when you give with, you know, an efavirenz, you know, based regimen or triplet for the first line, and it's not deemed clinically significant. So for ledivosvir, yes, it's reduced, but they say it's okay, but for vel, a little bit more of a problem, so probably not acceptable. And again, but then when you have soft ledivosvir with tenofovir, similar, with soft-vel, you see this tenofovir levels increasing when you have now the victim is tenofovir, and this is TDF, not TAF. And with soft ledivosvir, you're seeing these higher tenofovir concentrations, you know, around 30% increase, especially even when added to, you know, an atazanavir, darunavir-based regimen. So that's increase on top of increase likely, because we know that with these regimens, the tenofovir is already a little bit higher compared to, you know, an NNRTI-based regimen. So here's just a nice summary table of what I've tried to say. Again, just focusing on those, you know, the three drugs which I think in this region will be used, you know, sofosbuvir, really no real interactions actually, but when you start going to declastevir, remember the atazanavir, but not for darunavir or lopinavir. And efavirenz, you have to increase the dose, while for atazanavir you decrease the dose. Soft ledivosvir, not a real interaction with efavirenz like we said, so here it's only tenofovir-based interaction, similar for soft-vel. For efavirenz, no, nevirapine, no, but then you have the tenofovir as well. So there's not too many interactions, particularly with the drugs we have, so I think it's not too bad, but again, we have to be a little bit careful when prescribing this, particularly probably monitoring with the tenofovir. So I just wanted to have two slides on a new drug, and this is because this study is being done in Thailand and Malaysia. They have a new DAA called redivosvir. It's being developed by DNDi and in companion with a drug company in Egypt, I believe. And this is an oral NS5A inhibitor. It has pan-genotypic potential, and this is a study in 300 patients in Malaysia and Thailand, just showing very good SVR12, and then it actually depends on if they were cirrhotic or non-cirrhotic, but it was showing very good response, and the study's ongoing to look in more patients, look in genotype 6 as well, because in genotype 6 it looked a little bit low, but few patients, so this needs to be looked at. But in terms of the drug-drug interactions, again, we want to see what is the impact on, you know, efavirenz. So this soft redivosvir had no real impact on efavirenz. For tenofovir, again, a little bit increase, you know, when you're adding the soft redivosvir, but perhaps not as much as the others. And if you look at the raw numbers, it's not so much. So soft redivosvir, at least with the ARVs being the victim, let's say, we haven't yet looked at the impact the other way around on redivosvir, but it looks relatively safe, for example, with efavirenz and tenofovir, TDF at least. So I just wanted to put two quick slides at the end for non-ARVs, because, you know, this presentation title was the interactions between new DAAs and ARVs, but I still think it's important that in your clinical practice you may be seeing this, and, you know, you have to give immunosuppressants, but for the drugs that I was really focusing on today, soft-vel, soft-led, and sofosbuvir, you can give, you know, the common immunosuppressants, cyclosporin and tacrolimus, to be given, so that's not a bad thing to give with those. At least the drugs that, at least in Thailand, that I believe will be used, is not really interacting. Now, for statins even with antiretrovirals is complicated, but now we're adding on the HCV. The statins is a little bit complicated. Again, it depends by statin. It depends on the dose you prescribe. But what I want to really emphasize is, obviously we need to check with the interactions with the statins and the DNAs. Check for the statins and the HIV. So I think there's not a huge amount of data out there, But again, as you're going to be giving these with, older patients, probably for hepatitis C, some will be on statins, and this is something you have to consider when prescribing. So obviously we can't remember all these things. Even after this presentation, when you're having dinner tonight, you've probably forgotten most of them. But I think the reason is that we can have, good resources. This is mentioned a lot in a lot of drug-drug interactions presentations. The HEP drug interactions website, where you can quickly plug in, and they will try to give you perhaps not a definitive answer, but maybe give you an idea of the potential risk for an interaction. It might say like a green, yellow, or orange, or red. Obviously red, is probably not a good, but for orange, you don't really know, so it's a little bit harder to interpret. And then for the Thai guidelines, obviously for the Thai participants, there's a lot of information in the most recent guidelines on hepatitis C management. So in summary, clearly the use of efavirenz, which is really a moderate inducer, as we see for lopinavir with antiretrovirals, it's not recommended with soft-well, but it is recommended with soft-lead, despite that sort of slow decrease in the levedivir concentrations. So that's probably the best regimen to use. Co-administration of soft-well and soft-well with tenofovir on the opposite side is now increasing the tenofovir. So we probably good to monitor the tenofovir-associated adverse events, creatinine clearance, and just to monitor that during the early stages of the treatment. For declastevir, if you're giving atazanavir or efavirenz, it may be an issue whether to increase or decrease the dose. For the other boosted PIs, it seems less important. But in general, and again, like I say, you're not going to remember all these regimens. It's just really important to be vigilant of the possible drug-drug interactions that could impact the drug efficacy and safety. And then, of course, these are only the drugs that we know they're taking or being prescribed. They're probably on herbal medications or something over the counter or from their local market they just bought. So we cannot predict everything, but I think we just try our best to try to see, and this is an important question to ask them when prescribing, are you taking anything else? And they normally would tell you, but sometimes it's not exactly clear what it is. They've just bought it in a bag somewhere. But well, with that, I'd just like to thank particularly Jennifer Kaiser, who I asked for some advice about the key drug-drug interactions, and then for your attention. Thank you very much.
Thank you, Dr. Tim, for the very comprehensive summary of the DAs. Even though the uptake of DAs is low in the region, hopefully in the coming years, we get more access for the DAs. Are there any questions for the audience? Okay, so that's it. So today, this is the last session, and then we got another half day for tomorrow, and we will start at 8:30 a.m. tomorrow. Thank you very much. Enjoy the Bangkok.